Right, so before starting everything, you should set up monitoring and open an IV access. So set up basic monitoring like 5 lead ECG, pulse oximeter, capnography. So attach the airway adapter of the capnometer to the breathing system and set up non-invasive blood pressure monitoring. So open an IV access, decide what is the correct size of the intravenous cannula for this patient and for this procedure. So you can go for a smaller gauge intravenous cannula if this surgery is not going to be a surgery where you expect a lot of bleeding. And so it would be good to start the patient on a crystalloid intravenous solution like normal saline, Hartmann's or Sterofundin. Start at a rate like 100 milliliters per hour for an average built adult. So monitoring is set up, and now you should see the normal heart rate and heart rhythm on the ECG. Blood pressure may be slightly high because the patient is anxious by this time of the day. Some patients are very scared. So you need to talk to the patient, allay anxiety, and you may use a small dose of anxiolytic like intravenous midazolam, 1 to 2.5 milligrams depending on the body weight of the patient, and start pre-oxygenating patient with 100% oxygen. Generally 6 to 10 liters per minute of oxygen depending on the patient's size is essential. So keep looking at the end tidal oxygen. So once the end tidal oxygen is above 80%, that generally assures that the functional residual capacity of the patient is filled with oxygen. And you should also see the capnograph pattern correctly on the capnometer. So if the blood pressure, heart rate, oxygen saturation, EtCO2, if all these numbers are looking good, and you are ready now for induction of general anesthesia. And generally if this is a routine surgery, the environment should be calm and quiet and peaceful. You have your assistants, equipment are ready, you have checked everything. Now you start induction of anesthesia. So if you have two anesthetists, one anesthetist can do the pre-oxygenation and attend to airway. Meanwhile, the other anesthetist can attend to administering intravenous drug. So generally we administer the intravenous opioid dose first. So it will be generally intravenous morphine 0.1 milligrams per kilogram body weight, or if it is pethidine it will be 1 milligram per kilogram body weight. And after a couple of minutes, now is the time to start induction of anesthesia with your induction agent. Generally it's propofol these days, so better if it is so generally it is intravenous propofol used these days. Propofol is very irritant to veins, therefore administer a small dose of lignocaine, and generally we take 1 milliliter of lignocaine for 10 milliliters of propofol. So if it is going to be 20 milliliters of propofol for a standard average built adult, it will be 2 milliliters of lignocaine. Administer it into the cannula so that the next drug, which is propofol, which is a known vein irritant drug which is going to cause pain, will not be painful for the patient. So administer some amount of lignocaine and then followed by propofol. Now patient is quietly going into sleep, and you are looking at the monitors, numbers are stable, and the blood pressure may come down a little with vasodilatation related to propofol. And check for ability to ventilate, which we call test of ventilation. And if you can ventilate, you can now administer atracurium, and the induction dose of atracurium is generally 0.5 milligrams per kilogram body weight. And after administering atracurium, you take over breathing gently, and by looking at the oxygen saturation and end-tidal capnography, blood pressure, pulse oximetry, ECG rhythm, you are gently ventilating the patient. And you should now look at the chest of the patient, where the patient's chest is moving nicely. And meanwhile you can have 1 or 2 recordings of blood pressure intermittently to see whether the blood pressure has gone down due to propofol. Some amount of hypotension is expected with propofol.
After administering the intravenous anesthetic solution and the non-depolarizing muscle relaxant, you have to ventilate the patient for about 2 to 3 minutes till the neuromuscular blocking agent starts to act. During this period, you have to ventilate the patient with 100% oxygen and about 2 times of minimal alveolar concentration of the volatile anesthetic agent, which could be isoflurane, or sevoflurane, or desflurane. And do not use nitrous oxide because you want to fill the functional residual capacity of the patient with 100% oxygen to increase the safety margin in case of a difficult intubation and a period of apnea. By now you should be ready with the correct size endotracheal tube and a tube one size smaller, correct size laryngoscope blade, endotracheal tubes, stillets, bougies, and laryngeal mask airways and oropharyngeal airways to be used if necessary, and also a suction in working order. You should start attempting at intubation only when the patient is deeply anesthetized and very well relaxed. So to check whether atracurium or the other muscle relaxant that you have given is working, either you have to check neuromuscular monitoring or wait for a standard time. For instance, if you have used atracurium as the non-depolarizing muscle relaxant agent, you have to wait about 180 seconds for it to act optimally. Now for direct laryngoscopy and intubation, you should bring the axis of the mouth, pharynx and the larynx into one line of vision. For that, place a pillow under the head and flex the neck, and also do a gentle extension of the head. If you are a right-handed person, hold the laryngoscope with your left hand and insert the endotracheal tube using your right hand. Insert the laryngoscope blade gently into the right side of the mouth, displacing the tongue to the left side and into the submandibular space. Now, gently slide the laryngoscope blade down the midline till the tip of the Macintosh blade lies in the vallecula, which is just anterior to the epiglottis. Make sure the tip of the endotracheal tube stellate is not jutting out through the distal end of the endotracheal tube. Try to see the laryngeal opening. Lift the laryngoscope upwards towards the roof. Do not lever the blade at this moment. External laryngeal pressure in the form of burp, backward, upward, rightwards pressure applied on the thyroid cartilage will be very helpful to visualize the glottis. So now if you have tried about twice and if you find it difficult to intubate, now is the time to do some modification to your technique. So one of the first things that you can do is to pass an endotracheal tube stellate through the endotracheal tube and then reattempt at intubation. If that method also failed, now you can do a further modification to your technique. Now you can try to pass a bougie into the trachea through the glottis and railroad an endotracheal tube down the bougie. If you have not been successful by now, since you are a trainee anesthetist, you should call for senior help or call the consultant now. In between attempts of intubation, you should maintain 100% oxygenation and deepen anesthesia with the volatile anesthetic agent. Continue monitoring and try to maintain vital parameters stable as much as possible. Right now, your consultant took over intubation, and with her experience and skills, she managed to intubate the patient. So in this learning session, we learned how to intubate. We learned the correct technique and how to maintain vital parameters and to maintain 100% oxygenation in between intubation attempts.